Dear colleagues, it is my great honor to present in this great conference the title of the lecture, Sudden Cardiac Death in Structurally Normal Hearts or Apparently Normal Hearts. I am Samir Rafla, Emeritus Professor of Cardiology in Alexandria University. Sudden cardiac death definition, natural death due to cardiac causes within 1 hour or when there is eyewitness, or 24 hours when there is no eyewitness of the onset of acute symptoms in a person with known or unknown cardiac disease. The time and the mode of death are unexplained. Possible causes of sudden cardiac death in structurally normal hearts, channelopathies as Wolff-Parkinson-White syndrome, accessory pathway, long QT syndrome, Brugada syndrome, catecholaminergic ventricular tachycardia, early repolarization syndrome, short QT syndrome, and in several cases, drugs may have been triggering the sudden cardiac death. For example, the combination of a triggering event and a susceptible myocardium has evolved as a biological model for the initiation of lethal arrhythmia. The electrophysiologic effects of cocaine have been examined in tissue preparations, animal models, and human subjects. The drug has class 1 type activity with significant effects on myocardial refractoriness. In addition, cocaine can have a pro-arrhythmic effect similar to that induced by quinidine as the result of triggering activity from early after depolarization associated with a prolonged QT interval. Thus, cocaine ingestion could induce ventricular arrhythmia independent of its effects on coronary arteries. Here, one study reported that sudden cardiac death, we can divide the patients into some patients after autopsy revealed some abnormality, and with autopsy, no abnormality could be found. In any case, the mortality of sudden death is more in males at any age, 20 to 30, 30 to 40, the males are more than females. And this is the distribution of sudden cardiac death in the study. The causes after autopsy, they found apparently it was normal, but they found coronary artery disease in 65%, congenital anomaly as abnormal coronary origin in 14%, myocarditis 10%, arrhythmogenic right ventricular dysplasia 4%, hypertrophic cardiomyopathy 4%, aortic stenosis 2%, coronary artery dissection 1.7%, unusual findings 1.7%, idiopathic dilated cardiomyopathy 1%, sarcoid 1%. Now we come to every cause one by one. We start by early repolarization, association of elevated J point at the descending limb of the R or between the R and the beginning of the ST is called early repolarization. We have to differentiate between two types: early repolarization, raised J point, and raised J point with elevated ST segment, and the elevation is upward slope. This example, 43-year-old woman with paroxysmal atrial fibrillation, episode of chest pain couple of years ago with slightly elevated troponin, normal coronaries, non-catheterization. Patient is a runner with no history of syncope. Brother has atrial fibrillation and had cardiac arrest resuscitated at age 40 and ICD implantation. You find in her ECG the following: RSR' in V1, raised ST with downward slope in V1, and J point elevation in lead 2. So there is here suspicion of Brugada and early repolarization. What you tell the patient: go home or implant the ICD, or stay without any intervention till you get sudden death. Of course, you tell her you have to put ICD. Another example, 23-year man, perfectly healthy, but his younger brother died in the shower. He has typical Brugada syndrome, typical early repolarization with two signs: raised J point and elevated ST segment. Here, J point and elevated ST segment. Here. So you tell the patient, go home or you must put ICD. Of course, you must put ICD. His younger brother died suddenly in the shower. You don't wait till the patient dies. we have to differentiate between early repolarization alone and raised J point and the raised J point with raised ST segment. This is not pathological, this is pathological. Again, elevated J point with or slurred R with raised ST, the raised ST gives more risk of sudden death. Another example, here there is raised ST with upward slope. Young male in excellent health until he had cardiac arrest at age 15. So when you see raised ST with elevated J point, this is dangerous diagnosis. We finished early repolarization. We come to Brugada syndrome, raised ST segment in V1, V2, V3 with downward slope and RSR dash. What are the prognostic risk signs of sudden death in Brugada? This is a question in the cardiology exam. If the QRS is bifid with fibrillatory waves like this, if there is late potential, if there is induction of ventricular fibrillation in electrophysiologic study, if there is mutation in gene, so these are the risk factors for sudden death in Brugada. So when you see Brugada, you will not put ICD immediately. You will see if the patient gets syncope, VTAC, induction of VF in the lab, associated with early repolarization, associated with fragmented QRS. Again, another study. Fragmented QRS is a lethal sign. If the patient gets syncope, this is a risk factor for sudden death. Fractionated QRS, very important. Spontaneous type, this is very important. Brugada himself said, if the patient is type 1, the manifest, the raised ST segment is clinically manifest at rest, this is lethal sign. If it is only apparent by induction or provocation, it is less lethal. In this study, he found that induction of VF in the electrophysiology study is not a prognostic sign of death, but in another study, we found it is lethal. This is example of a Brugada, typical raised ST segment or RSR dash in QRS, and raised J point early repolarization. So combination of Brugada with early repolarization is lethal. Arrhythmia-free survivor in Brugada syndrome and with and without early repolarization. Without early repolarization, mortality is less. We come to another cause of death, R on T phenomenon, inducing VTAC, ventricular flutter, and then fibrillation. Another example of R on T inducing ventricular fibrillation and standstill. What are the markers of sudden death in patients with coronary disease? We speak about structurally normal hearts. The patient may have hidden or unsuspected coronary disease. If he is having signal average ECG abnormality, electrophysiologic study revealed abnormality, premature ventricular contractions more than 10 per minute, QT dispersion. We measured QT dispersion in one study manually. T-wave alternans, we measure T-wave manually in one study. If there is abnormal T-wave in leads. Measuring heart rate variability by the Holter monitor. Functional surrogates, low ejection fraction. Of course, this is apparent abnormality. Coronary artery disease risk factors, left ventricular hypertrophy, NIHA class, and beta natriuretic peptide. These are the markers of sudden cardiac death in coronary patients. Most important of all, gene abnormality. Congenital arrhythmogenic syndromes, we mentioned this before, but these syndromes are, some of them are associated with the structural heart disease as right ventricular dysplasia, hypertrophic cardiomyopathy, dilated cardiomyopathy, significant mitral valve prolapse, anomalous coronary artery, but others are associated with minimal or no structural heart disease, as long QT, Brugada syndrome, Wolff-Parkinson-White syndrome, idiopathic ventricular tachycardia, short QT, catecholaminergic ventricular tachycardia, congenital complete heart block. Underlying arrhythmia of sudden death, ventricular tachycardia in 62%, bradycardia 17%, torsade 13%, primary VF 8%. Now we come to another example of arrhythmogenic right ventricular dysplasia. There is right bundle branch block, incomplete right bundle, and S wave, epsilon wave on the QRS. This is the epsilon wave. When you see this patient, don't say to him, you are completely free. You must do magnetic resonance to check for the atrophy of the right ventricular outflow. The patient got ventricular tachycardia with left bundle branch block pattern, but with the right axis. Whenever you see ventricular tachycardia with left bundle branch block pattern and right axis, not left axis, remember the origin is from the right ventricular outflow area, and the causes most probably idiopathic right ventricular dysplasia. Now we come to long QT syndrome. This patient is having long QT and implanted ICD. He got ventricular torsade 1, ventricular tachycardia, and the patient gave electric shock, reverted him to sinus rhythm. Why the ICD did not give the shock immediately? We programmed the ICD to wait 15 seconds. The patient may revert to sinus rhythm by itself, or the pacemaker gives higher rate overdrive suppression. But all this, the arrhythmia did not subside, so the pacemaker fired. Why this delay? To spare the battery. Another example of long QT developed ventricular tachycardia. Now we come to Wolff-Parkinson-White syndrome. When you see very rapid atrial fibrillation, remember that it is accessory pathway. The only other probable cause, rarely, hyperthyroidism, thyrotoxic crisis. Now atrial fibrillation reverted to ventricular fibrillation. When I see sometimes Wolff-Parkinson with atrial fibrillation, I say to the patient, you must immediately go for ablation. Atrial fibrillation becoming ventricular fibrillation in the left portion of this panel, the ECG demonstrates atrial fibrillation with conduction over an accessory pathway, producing rapid ventricular response at times in excess of 350 beats per minute. If the RR interval is less than 300 milliseconds, the probability that he will go into VF. Now we come to another item. Catecholaminergic polymorphic ventricular tachycardia is an inherited arrhythmia syndrome, so-called channelopathy, is characterized by the occurrence of adrenergic mediated polymorphic ventricular tachycardia. Prevalence of catecholaminergic polymorphic ventricular tachycardia in the general population is unknown, but has been estimated 1 per 10,000. Although a rare disease, recognition is important because it is highly lethal, 15% mortality. Accordingly, catecholaminergic polymorphic ventricular tachycardia probably plays a significant role in autopsy negative sudden unexplained death in young individuals. We hear a girl exposed to sudden fear or anger or excitement and gets sudden cardiac arrest. Most probable cause, she was having catecholaminergic polymorphic ventricular tachycardia. The other possibility is long QT syndrome type 1. Type 3, the death occurs during sleep. This is example of ventricular tachycardia bidirectional, one above, one below, one right bundle, one left bundle. This is lethal. 12 lead ECG tracing during stress test shows the typical aspect of bidirectional ventricular tachycardia characterized by 180-degree alternating QRS on a beat-to-beat basis with a right bundle branch block pattern suggesting left ventricular origin. This happened during exercise. I get frightened when I see this. If I do exercise and the patient gets this, I will be in great trouble. Another example of ventricular tachycardia induced by catecholamines and ended in fibrillation. Current management of catecholaminergic polymorphic ventricular tachycardia, beta blockers, the first line therapy option to patients with this syndrome is beta blockers without sympathomimetic activity, in accordance with the this arrhythmia catecholinergic mechanism combined with exercise restriction. Exercise restriction is important. Implant, or we put ICD or verapamil or flecainide or propafenone, or left cardiac sympathetic denervation. We come to another item, non-ischemic ventricular tachycardia, high-risk subgroups, survivors of sudden death, recurrent unexplained syncope, idiopathic cardiomyopathy with syncope, hypertrophic cardiomyopathy with syncope, right ventricular dysplasia, long QT syndrome. These are the non-ischemic VT causes. Example here, the patient is having hypertrophic cardiomyopathy, implanted with ICD. The ICD found the patient got ventricular tachycardia, started to charge, and gave overdrive trial of suppression, but the tachycardia did not stop and reverted to VF. Then the pacemaker gave electric shock, 20 joule. 20 joule is high joule. Why the pacemaker did not fire immediately? Because to spare the, maybe he reverts to sinus rhythm by overdrive suppression. Clinical syndromes treated with ICD, cardiac arrest survivors, VTAC, not hemodynamically well tolerated, idiopathic cardiomyopathy with syncope or VTAC, hypertrophic cardiomyopathy with syncope or VTAC, right ventricular dysplasia, long QT syndrome, Brugada syndrome with syncope or positive electrophysiological study. Conclusion, the vast majority of sudden cardiac death patients had structurally abnormal hearts, but in as many as 30%, abnormalities were non-specific for patients with structurally normal hearts. At autopsy, clinical history combination uncovered potential mechanisms of sudden cardiac death in 57% of cases. So autopsy is important. Establishing structural normalcy is an essential prerequisite to making a diagnosis of the entity. However, focal manifestations of conditions such as myocarditis, cardiomyopathy, or small tumors in such cases, or discovery of small tumor. Furthermore, non-specific abnormalities such as interstitial fibrosis and the mild myxomatous mitral valve changes are difficult to diagnose. The gold standard for confirmation is by autopsy. Thank you. I hope I covered the subject, and the lecture is on the internet on many sites. Just ask Google and you will find it on my channel in YouTube by my name, Samir Rafla, or on another site on Facebook. It's called Samir Rafla Lectures, or on ResearchGate. So you can find the lecture in many sites in the internet. Thank you very much.